Are you watching Hippos thing?
No.
Okay.
Oh, are there drops?
No. Yeah, I invite you.
Oh, it starts on Friday. There's drops.
Oh. Would be like gold. Oh. You're gonna be Athena? Oh, do you want to go against each other, or because now would be a better time? Is Paul there?
That's true.
Yeah, why don't we do that? Here, let me.
I will go to my boat.
You have a sloop? Okay.
Or actually, can you go to us? Because if I joined you, I should be in the same like region as you, right?
Oh, yes. All right, let me leave game.
Oh gosh, I have this boat.
You don't like it? Oh, there. Oh, share your screen, not share mine. Ooh, Thursday, there's an update. Oh, okay.
What time do you have to go to work?
Like one.
Huh?
One.
That's very soon.
I mean, two. I'm waiting for my package to show up, Paul, and then I'll go.
Oh,
I have the
oh.
flexibility to go in anytime I want. That is sleep medicine training.
If you can go in anytime you want, can you not go in?
I could, but I still have 4 studies to do. All right, well, I spawn at some inconvenient location, but sure.
Huh?
I spawned at Port Merrick. Quite inconvenient
Why is that?
because I need a raise Reaper, but I guess
Oh,
not.
I guess that is a little inconvenient. Ever so slightly. Swear, Steve, I get banned for your boat's name.
I thought, you don't like this boat's name?
Oh, really? Did you raise your emissary?
No, it's all right. I'll go. Okay, I got Servants of the Flame. You ready to go?
Oh, yes. All right, let's go. Three, two, one.
Okay. Fight to the death?
Yes. Oh, did you not dive yet?
I did not.
Well,
Well, well, I'm diving now. That's okay. I'll raise on my next one. Oh shit! I thought it was gonna match with you. Oh man.
That's for bet.
Oh, is that Hippo? That's Hippo. You should probably say hi.
No, it's both just Kevin.
No, he changed it. He's changing it every day. I think that's him. Let me see his stream. Oh yeah, no, that's not him. Indeed, not him. Maybe he's looking for Hippo. Oh wow, he's gonna crowd control you.
Oh, he's on my boat. What?
Wow. After
Is he?
being stabbed, you just hop back on the wheel.
I couldn't get off.
You press F. I think he's gonna crowd control you and take you out. Yeah, you do well, Blondie. Yeah, yeah, yeah.
I didn't even see him.
I saw him come up after the first shot. He got you. Oh, downstairs. Maybe he's talking. He's talking. He's probably up. Yeah, he's probably up there. Oh, he's up there. Yep, yep, yep. He's up there. I will eat. Are you gonna eat? Oh, oh, he fell. Okay, guess we're not eating.
Shit, what a banana.
It kind of hurts.
Steve, why'd you tell me to do this?
I didn't know you're gonna be so terrible at PvP. I literally told you to eat, and it took you like the whole time to eat something. It's okay. It's okay. He will get off soon after he drags you overboard. He's back down. Yep. You're supposed to aim, but that's fine. Oh, he has a stealth skelly curse. I would run and eat. Oh, get him. He's up. No, up. He's up. Oh, Lord.
Why?
You know what? Just do whatever you think is fine to practice.
Why is this happening to me, Steve?
Because you're so bad at PvP, Paul.
Gold skeleton is obviously very good.
No, I think you would have killed him, except you just were not fast enough. It's okay. Just go kill him and turn a boat. Or just turn a boat. Yeah, he's in. Well, that is not gonna do well because you're already out of bounds. Oh, you're supposed to aim down. He's behind you. He's behind. Down now. Down. He's down.
Yeah.
He's behind.
Not fun, Steve.
You know what? Yeah, it's okay. I mean, it's you just you're bad at combat, close combat. It's okay. It's okay. Just scuttle and come back and vote because I've been trying to look for a match for this whole time while painfully looking at your screen. Didn't I tell you to aim down? I don't know how many times. You need to aim before you shoot, otherwise it's never gonna one hit kill them.
Who's the better ship name?
Wow. What did he say? What is he saying? I like knitting and crochet. He's like, get a better crewmate or something.
Get a better ship name.
Oh. Get a better ship name. I like knitting and crochet. Oh my god. Don't you just love the ship's name? What? I'm dying.
What's happening?
I love this ship name.
You love the chimney?
No.
Okay. Quickly. Just pick a. Okay.
What's up? How are you?
Did someone say something?
Me, Enrique.
Oh, wow. You've been here the whole time?
No, I just got in.
Oh, wow. Well, I did not know I was muted the whole time. I was in my competitive PvPing. Yes, you're gonna do well, Enrique.
Which PvP are you doing?
Oh, I'm doing Sea of Thieves while I'm waiting for my package to come. All right, I'm back on mute. I got a match. Paul, are you in?
2.
Can you hear me? Hello.
Hello.
Okay.
So, should I start or should Enrique start?
I think if you want to go first, and then we'll do the journal club after that.
Okay, sounds good. So today we're going to talk about the regression analysis. And when we talk about regression, and I'll share a screen, when we talk about regression, we're actually talking about a group of methods. These are statistical methods that are used to evaluate associations between a predictor or exposure and outcome. Now, regression can be adjusted for, right? So in regression models, we can look at the association between two variables, but we are accounting for confounding variables as well. So I said that it's a family of statistical methods. Today, we're going to talk about two specific ones. One is linear regression, and the other one is logistic regression. These are the most commonly used in biomedical literature. So what's the difference between them? The difference in every regression, actually, every specific regression method is about the outcome. And in linear regression, we're talking about continuous outcomes such as blood pressure, glucose levels, or body mass index when we look at it as units of BMI. When we talk about logistic regression, the outcome is dichotomous, binary. We're talking about the presence of disease versus the absence of disease. Another group of regression methods that we're not going to talk about today, but is also popular in biomedical research, is Cox regression, which is a statistical method that is evaluating time to event. For example, if you want to look at a group of people and see when, if men are more likely to get stroke, for example, earlier than women, then you would use Cox regression, or time to event analysis, it's called. So back to our two regression methods, we're gonna talk about linear regression, which again is designed to examine associations between exposure and continuous outcome. And when we do linear regression, we basically look at three components in the output. The first one is the beta value. This is the coefficient of the predictor. And the value of the coefficient of the predictor, let's say that we're looking at association between age and blood pressure. The coefficient of age will tell you whether blood pressure increases with age, that's going to be a positive beta, or decreases with age, that's going to be a negative beta. And the output is going to also have a confidence interval, the lower bound and the upper bound of a confidence interval. And that will show you the potential values of the beta if we were to repeat this analysis again and again with different samples. And also a p-value. And if you heard my talk about p-values and confidence intervals, you know that they're redundant. One of them, that is the confidence interval, is sufficient because it implies the p-value in them, which means that if the confidence interval has 1 in it in the band between the lower and the upper bound, if it has a 1 inside, then that means that the association is not statistically significant. Okay, so linear regression. So I talked about the beta, right? If it can be positive or negative. So a negative beta would tell you that with every increase in the predictor, the outcome is going to decrease, and you will see a negative association. A positive association means the beta is going to be positive, but also that would indicate that with increase in the level of the predictor, the outcome will also increase. And there could be no association. In that case, the p-value is going to be greater than 0.05, and the confidence interval will include 1 in it. So how is regression analysis differs from correlation? So there are 2 things. First of all, regression allows you to adjust or account for other variables that may also explain the outcome. The second thing is that it gives you a magnitude of the association, and it gives you directionality. So for example, when you do correlation analysis between age and blood pressure, you don't assume anything about the direction of the association, whether age is affecting blood pressure or blood pressure is affecting age. When you are doing regression analysis, you have an assumption of what is the independent variable and what is the dependent variable. So these are important things to remember about the differences between them. How do we interpret linear regression? So when we see a positive beta, we say that every 1 unit with an increase, let's say, of age, the mean increase, if the beta is positive, the mean increase in blood pressure is going to be the value of the beta. So if the beta is going to be 2, for example, not -2, but +2, we will say that every 1 year increase in age, the mean blood pressure is going to increase in 2 units. If it's negative, it's going to be a decrease. Now, sometimes the predictor or the exposure is not going to be continuous. It's going to be a binary or categorical. In that case, we cannot talk about increase of 1 unit in the predictor. We can say that let's pick women and men. Let's say that being a woman is going to be associated with an X increase or decrease in the average value of the outcome. We cannot say that it's a 1 unit increase. We say that being a woman or being a man. So you're basically comparing here categories. You're not comparing levels. And logistic regression is a different type, because here we're looking at a binary outcome. We're looking at having a disease or not having a disease. For example, in linear regression, we would look at apnea-hypopnea index. That's a continuous outcome. In logistic regression, we would look at either disease severity, which is mild, moderate, severe, or we can say the presence of OSA or the absence of OSA. And we talked about the beta as a way to interpret the results. Here we have a beta, but we exponentiate the beta, and we're actually ending up with odds ratio. That's the e to the beta. And so when we look at e to the beta, we're talking about the odds of having the outcome. So for example, if we're thinking about age and the risk of sleep apnea, we say that every 1 year increase in age is associated with 1.4 increased odds of having sleep apnea. So here we're talking about odds. We're not talking about mean value of an outcome. We're talking about an odds ratio of an outcome. So here's an example. We're looking at maternal age and pregnancy complications. We have a large study of 7,000 women, and so we know that it's going to be sufficiently powered for statistical analysis. And so we collect the age and the birth outcome. So the age can be modeled in two different ways. The first way, we can look at age as a continuous outcome. We're talking about maternal age here. And the second way to look at it is to create categories using 40 as a threshold or as a cutoff. So we would group the women, the 7,000 women, into two groups, women who are younger than 40 and women who are 40 or older. So the question is maternal age is associated with blood pressure? And so when we model blood pressure continuously, we can look at the beta, and we can say that every increased year of maternal age, we have an increase of 0.27 in the mean level of hypertension or blood pressure, sorry. If we look at hypertension, yes or no, and maternal age, as also with the threshold of 40, we are applying logistic regression, and we can say that maternal age over 40 is associated with 23% increased odds of hypertension. So these are the differences between logistic and linear regressions. And now when you do, it doesn't matter if you do linear regression or logistic regression, you can account for other variables that can be explaining. For example, what can explain the outcome, a history of hypertension, body mass index, maybe education level, maybe parity, whether it's your first pregnancy or second pregnancy. There's a lot of things that we can do with that. So this is how a table looks like. In this table, we have a list of all the independent variables, also called explanatory variables, or predictors. And you can see that gestational diabetes, for example, that's the one in the middle, it has 1.8 value. And then everything else has a value and then parentheses. So the maternal age is categorical. Everything that has parentheses implies a categorical or binary outcome. And the gestational diabetes, I don't know why it doesn't have parentheses, but I'm assuming they're looking at glucose levels here. In any case, you can see that the p-value is significant in all of them except the gestational diabetes, and that one is not included in the confidence interval. But the interpretation is, let's say that we're looking at maternal age, is that every 5-year increase in maternal age is associated with 4% increase in the level of, or the risk of the outcome, which is preeclampsia here. Another thing I wanted to say here, that we are looking at maternal age, but accounting for all of the other predictors. We're accounting for the parity of the person. We're accounting for smoking status, for pre-pregnancy hypertension, for gestational diabetes, and also for BMI. And so I hope it was informative, and please let me know if you have any questions. And if not, we can switch to Journal Club. Thank you.
Thanks, Galit. Enrique, whenever you're ready.
Okay. Let me just open my. Okay, you're able to see the presentation?
Yes.
Yep.
Okay, okay. So was kind of lucky to find this article. It's pretty new from just this year, February. Um, Dr. Acho actually met one of the authors, and she worked with her in Pennsylvania. Um, it was brought to my attention. It was very interesting for me since one of the few things we see, or the most of the things we see here in the clinic, um, it's resistant symptoms after a well-titrated CPAP or a well-treated OSA. We still see patients with depression, fatigue, sleepiness. So this article was really important for me. Um, so that's why I chose this article, since it's one of the things we encounter, one of the issues we notice the most with most of our patients. So what else we can offer other than the other medications? So with, of course, with OSA, even with great treatment, we can have still experience people with, we have patients experiencing daytime sleepiness. It is thought that the process is due to the recurrent hypoxia and septal fragmentation that happened for many years, could be before the diagnosis. There is also already, it is thought that this injury to the brain, to the neurons that help with the sleep, it's promoting these issues. On top of having the daytime sleepiness, a lot of these patients will have issues with their sleep cycle. There's some circadian misalignment. There's changes in their daytime vigilance. There's mood disturbances and cognitive disturbances. So that's another kind of a symptom that people tell you, like it's concentration issues. Even that we fix the OSA. Sometimes these patients continue to have a circadian disruption. Other than stimulants, there's not much normally we can do about it. So this particular test tested the acceptability and efficiency of bright light therapy to improve sleep, circadian rhythms, and symptoms resistant to CPAP on patients with sleep apnea. It was done in Pittsburgh, PA patients. The patients who completed the treatment were 14. The patients were supposed to have 4 weeks of bright light therapy or sham therapy, but after 4 weeks they changed, and they also did the sham or BLT. So all of the patients did both. There was a week in between of washout where they didn't use any sham or BLT. And of course, there was activity done before the study started for a week to monitor these patients. And there was activity done while the testing was performed in those weeks. There was measurement of sleepiness, depression, and symptoms related to the functional impairment. So the patients that they work upon were patients between 45 to 65. Of course, they have the diagnosis of OSA. They were compliant with most of their CPAP therapy. The average Epworth was 10. They were having around 6 hours or more of sleep. They didn't have any history of macular degeneration or other uncontrolled medical problems, no history of bipolar or other sleep-related issues. There were no changes on the medications. Also, they didn't have any kind of eye surgery, or they haven't been using bright light therapy in the past few weeks or months. So these are the baseline of those patients. You see the age, was the sex, there was the CPAP usage, more than 4 hours, the Epworth, the value of Epworth overall of the patients, the depression scale, and the functional outcome of sleep questionnaire. So this is the number of patients they first tried to enroll. They had 56. They ended up with 15. They allocated patients with sham and bright light therapy, and then they did a follow-up, and they exchanged patients to do the other treatment, sham or BLT. At that moment, one other patient withdrew from one of the groups, so we ended up only with 14 patients. Not me, but the people in the study. So that we were explaining that it was like those 15 patients, they did activity before, and while the therapy was performed. So they were using also for 60 minutes the therapy every morning. The sham bright light therapy, if you were able to read it up on the study, they used a particular kind of a headset that was very similar to the one they used, but they were blocking the blue lights and green lights to be sure that they had any benefit. And this kind of a sham light, they have been using it in other studies in the past, so it's nothing new, apparently. Sleep was assessed with the wrist actigraphy. Epworth was used. The quick inventory depressive symptomology report was also used, and the FOSQ-10 was used to measure the functional outcomes of sleep. So what were the results of this study? Compared to sham, the active treatment reduced wakes after sleep onset for 4.1 minutes, but the total result of total sleep was actually also reduced. So there was less time in between sleep or wake after sleep, but they actually slept less. Depending on those total sleep was even actually even less if they were actually having less and less light. So here in those patients who they were in treatment and also affected by late light, they noticed a decrease in their total sleep time. That was the total sleep was at 188 minutes. It was around 16 minutes less. Now, but also the interruptions of sleep, it was less around 4 minutes. Bright light compared to sham did not increase the level of activity whenever the patients were exposed to more light during the day. But it did increase whenever the days were shorter, and also increased the amplitude of the circadian rest rhythm activity. So this is one of the images that show whenever patients were having regular day sleep, daylight of 12 hours with therapy, there was no real change in their activity level from midnight to 6. But compared whenever the days were shorter, they actually, whenever they were exposed to treatment, they were more active, those patients. So mostly whenever those days were short. Across all conditions, most of the time, the daytime sleepiness did not change, but it was superior to sham whenever the daylight was short. Also with depression did not affect whenever did not change too much on the days were long, but actually it changed whenever it was the daytime was short, and a little bit superior when the sham inactive sequence was. So this one is the Epworth, if taking into consideration the daylight, whenever it was the daylight with treatment. So almost a point. And this was the activity score with the daylight and sham treatment. Apparently. Depression, sorry. And then for the functional, there's no change. There were no changes in the functional impairment with or without treatment. They did notice, of course, that bright light therapy can consolidate sleep and boost the amplitude of the rest activity rhythms, improve the self-reported sleepiness and depressive symptoms during shorter photo period times. Um, so as we were discussing, like the treatments were the treatments were actually overall better when the daylight was shorter, um, and also were better whenever the treatment was given first, even first instead of being the sham first. Um, so depression was actually much better controlled whenever treatment was given first, other than sham. So thinking that addressing the issues in the first few weeks was more noticeable than the second time around. So morning treatment light was associated with better consolidation sleep-wake cycles and reduced time of daytime sleepiness. Um, and the depressive symptoms in patients with OSA that don't respond with CPAP whenever those shirts were shorter. Overall, BLT is well accepted, it's inexpensive, it's safe. With this kind of therapy, a lot of issues. I had a lot of issues with the study. I like, the way we can use other modalities to treat these patients, and it is I think something to keep in mind. I think a lot of in this case with patients living here up north, when we have a lot of months with short daylight. So if we have an improvement in some of the symptoms of daytime sleepiness, depression, and changing their activity in their activity levels, um, I think it's something to take into consideration. And of course, most of our patients are in the same range of patients we're seeing in this study. Um, Maybe the type of patient, it's kind of difficult to it's kind of a negative for this particular study, because they were mostly those BA patients. Um, I will have liked also to see more younger patients, maybe in their 20s, 30s, maybe peds, if that's maybe a case. The study was, I think the amount of patients was a amount really small, just 14 in total. Um, um, I will have liked to have a baseline of the studies, like even before everything started, if it was possible, looking at the Epworth, looking at the PHQ-9, the severity of the AHI whenever the patient was diagnosed with OSA, and compare it later on. What was the AHI at that moment? What was the PHQ-9? Maybe they still have depression, but how better, or how what was the before and after with treatment. Um, um, well, of course, all these patients, of course, most of they were retired. What was the level of activity? What was the actual amount of exercise or activity we're doing at this moment in life? It was also important for me to know. In a lot of these cases, maybe other medications affecting their sleepiness. It will be kind of nice to see what all the medications they were taking, that I don't have the list for those patients. They just say that they were not uncontrolled in non-controlled disease and no other medication in the past few months, but we don't know what medications they were taking at that moment. Of course, history of MI or things like that. So I think there's more to do in a different and in a bigger, maybe more patients, maybe a better spread, and more information on the baseline before PAP, where maybe they can give us more information to help these patients. I don't know if any one of you read the study. There were some questions about it. That you liked it or not.
Thanks, Enrique. There's a question from Punita. How did they adjust the daylight duration?
So they did adjust it. So they actually adjusted they adjusted for the daylight duration and the daylight for the patients, and even the altitude of the sun of with every patient. The exposure was 60 minutes every morning. But yeah, they adjusted for, of course, they use particular, give me a moment. They took into consideration even the sun and the altitude of that moment, the variables of the sunlight, and they were calculated with a specific calculation. They had a specific like a formula that I cannot even tell you myself, but it's put in the statistical analysis. Whenever I was reading with Dr. Gavidia, was not kind enough to help me, but it was a little bit complicated. But they took into consideration that for all the patients and the location they were at, and the photoperiod length of the year. They took the year, the power of the rest activity rhythm on the two phases. But yeah.
So I think Roma has a question as well. I think I missed it, but how long was the exposure for the bright light therapy?
60 minutes in the morning.
So I was curious about the exclusion criteria for people with poorly controlled blood glucose. I don't know if you had any other insight on that.
I think maybe with poorly controlled diabetes and maybe fatigue and generalized, they were concerned about that. And I don't know if, well, yeah. And of course, the eye surgery just because of the light therapy.
Right.
And
yeah, Todd and I were just kind of having a sideline discussion about bright light therapy and blood glucose control. I think there's maybe mixed evidence about what it does to blood glucose control and insulin sensitivity.
I thought maybe there was like, they didn't talk about AHI. They talk about, sorry, the H1C, and they didn't want patients, who they have, I think more than 8. Let me see here. And my thought process was because of ongoing fatigue. Planning to have a surgery. No, I was reading some, I think other location, but but yeah. I think they should have done just a little bit more of adding more information to each patient. What were the common medications they were taking? What was the initial AHI before the diagnosis of OSA? How many years of diagnosis with OSA? What was the Epworth initially before treatment? What was, so to see the comparison. So yeah, they didn't want to patients above 8.5 A1C.
Mm-hmm. And then Ron Gavidia is asking, will these results, would you recommend this intervention for people with EDS in the context of optimally treated OSA?
So it's very interesting. Like they were talking in the study that, of course, these patients, they didn't have any kind of circadian rhythm disorders. Um, um, I guess in Pittsburgh still, the winters are not maybe not as bad hours, but uh, maybe similar, and the amount of daylight is also maybe not great. Um, but I guess it doesn't hurt. But again, with real the amount of patients they did the study, it's still I'm a little bit hesitant. Um, but as we already tell patients, try to get enough sunlight in the morning, try to get out, try to be active, try to the other way around whenever it's at night. Um, you know, Try to avoid light. But with patients who have already ongoing issues with depression and daytime sleepiness, uh, I guess it's not a bad idea to start recommending in some of those patients. Even if it's 1 point, I think 1 to 2 of Epworth, it's somewhat noticeable. 2 points.
And again, I mean, if you have to recommend bright light, you have to have a specific lux, right? Certain light index that you have to give rather than a regular, you know, house light.
Yeah, so the one that used here, there was a green light, a green blue light, dominant wavelength light of 500 lux. Um, that's what it's called, Rate Timer, the brand. That was the one they used. And yeah, 500. And normally that's the bright light therapy I have seen is more than 500 lux, or I don't know how that. Normally the one I have seen for seasonal affective disorder is actually much more. I don't know, because of the proximity of the eye, it's different. I don't know if we normally have recommended this kind of light therapy or this kind of glasses before here, or you normally use the lamps. They're just like desk side.
We've used these in research studies, and we've loaned them out to patients, these retimer glasses.
Yes.
Yeah, and we have, they're Dr. Burgess, Helen Burgess, and Dr. Swanson, Leslie Swanson have used them in research protocols with good success, including like a sham one, like was described here, where they've got like an actigraph in the glasses, so that you can tell if people are actually using the glasses.
And doctor, like those sat lamps that normally people use of 10,000 lumens, why is this like just 500?
Well, it's much closer to your eye, and it's
Just because the
more
proximity, right? Okay.
yeah, and it's a more specific light. What do you call it? Resolution? No, that's not the right word. On the spectrum, it's a more defined circadianogenic, if you like, spectrum of light, and it's close to the eye, so you don't need as high, obviously you don't need as high a brightness to deliver
Mm-hmm.
it. And also, most of those lamps are not actually 10,000 lux. You have a meter. They're closer to like 2,500 lux for the most part.
Oh. Mm-hmm.
That's all I have to say on the topic.
Yeah.
I don't see any other hands up. And if anyone else has a question or an observation, if you'd like to unmute. Okay. Well, great job, Enrique. Thank you. And thank you, Galit.
Thank
Well
you.
done.